What is obesity? Like, what is it exactly and what defines it?
A question that seems simple but is super controversial.
Visceral fat versus more superficial fat. Can you see both?
Absolutely. With diabetes, about 80% chance of curing diabetes with bariatric surgery, so they can be off of all of their diabetes medications
Wow.
with normal blood sugars. We consider obesity to be a disease, often a disease of poverty, access to healthy foods, access to healthy lifestyle, to resources, to treatment. You can't talk about weight loss without talking about Ozempic, so I want to sort of bring this back again to the hormonal balance. Does dieting work for weight loss? It's not very effective. They've done trials comparing different diets.
Hello and welcome to another episode of Beyond the Scrubs on CubeCast, a new and original podcast show. My name is Sarush and I'm your host. Today's episode is about obesity and weight loss. We'll be talking about what obesity is and its increasing prevalence in our society. We'll be going in depth about the mechanisms and the physiology associated with weight gain. Concurrently, we'll be talking about weight loss and the management of it. Specifically, we'll be talking about the best dietary approaches, lifestyle changes and behavioral changes, as well as the roles of medication and surgical procedures on the weight loss. Today's guest is an internal medicine specialist specializing in weight loss and obesity medicine. He was born in Saskatchewan, Canada, and he did his medical school and residency at University of British Columbia in Vancouver, Canada. He did 2 extra years of continuing education and training in Vancouver and Toronto in obesity, hypertension, and cardiovascular risk management. It is my honor and privilege to have Dr. Jesse Bittman on the show. Jesse, thank you so much for coming on the show.
Thank you for having me here.
I appreciate it. So before anything, tell us what you do exactly. What is an internist specializing in obesity and weight loss? What do you do?
Yeah, so first I'll tell you what an internist is because most people don't know. So internal medicine is a specialty within medicine, and we focus on basically all medical management of patients, excluding surgery, excluding children. So if you have a medical problem and your family doctor needs some extra help managing it, they might refer to us. And other specialties, cardiology, infectious disease, lung specialist, respirology, kidney specialist are all subsets of internal medicine. And I'm at the sort of more general level of that.
Internal medicine. And then so you did some extra training to become familiar and focus on weight loss and hypertension and obesity medicine.
Exactly. So the internal medicine residency is a minimum of 4 years, and I spread it out into 5 years and did extra training in hypertension and obesity management, as well as cardiovascular risk management and other specialties. And I went to Toronto, as you mentioned, to do some extra training with specialists there, as well as in Vancouver.
Perfect. And you've been practicing a few years, but you're not working in the hospital setting. You just work in a clinical setting.
Exactly. So I've been practicing about 7 years now.
7 years.
And for the first many years, I split my time between the community and in hospital medicine. And over the last 7 years, I found myself leaning more and more away from hospital medicine and towards the community, towards clinic. I found that's where I was getting more satisfaction.
More satisfaction.
And so I just 2 years ago gave up all hospital medicine.
Perfect. So tell me a little bit about your background. I know you were born in Saskatchewan, Canada, and then you moved to the West Coast.
Exactly. Yeah. So I moved when I was very young. I don't remember much about Saskatchewan, and I don't mind that in the winter when I look at the weather across Canada. It's a
bit nicer here than
here. Yeah, exactly.
So you grew up in Vancouver and you went to school here, and obviously you did a medical school at University of British Columbia, Canada, and internal medicine. So tell me a little bit about that experience and one of the reasons that you chose to go into medicine.
So I've always been interested in science and been curious about understanding how the world works and trying to sort of explain why things are the way they are and how they work. And I've always sort of gravitated towards that in the human realm and trying to understand sort of why we are the way we are and how the body works. And then my uncle was a physician in the US, and I always sort of was thought it was interesting what
Yeah.
he did and the balance of his way he could understand things and speak with patients and the sort of what his job was like. And so then it just more and more I realized that's what I wanted to do was be a doctor.
Be a doctor. So did you decide mostly in undergrad that medicine was your path, or was it mostly like during teenage years in
So
high school?
it was always something that I thought about, but I
Yeah.
wasn't sure. There were other things I was considering, and then in undergrad is when it really sort of solidified. This is what I'm interested in, and also a career that I can
That you
that I
can.
can do.
Perfect. How was the process of getting into medical school? How was that?
Yeah, it's a lot of work. It's a lot of work. It's not an easy process,
Yeah.
and mostly it's luck. I
Yeah, there is a bit of luck factor to it too. Like when you get in.
Exactly. So it's obviously like you have to put the work in, but if you aren't lucky, then it just isn't going to work anyways. You can put all the work you want in, but if you aren't set up with born in the right place at the right time, and then also, do the right things, and they just like your application and all of that is I always think a bigger part, because I know friends and colleagues who
Yeah.
didn't get in or took much longer to get in, and I can't think of what actually separates us and what they could have seen different on the one
Yeah.
application that you do. How could they know? And I've actually sat on the other side of it, and it is so difficult to decide. Everybody looks amazing on paper, and
Yeah.
they've done these amazing things, and more amazing than all than things I did. And you're like, okay, how am I going to pick between these people? And
That's
it's
true,
very
actually.
difficult.
Yeah, and sometimes you have to only select. I think in one of the episodes that I did, we talked about that how it's like 10% or under of applicants that get
Yeah.
into any sort of medical program. So I think there's like 2,000 applicants or something, and they take like maybe a couple of hundred, right, in some
Yeah.
of the programs. So it's very difficult. But I guess being at the right, obviously you have to have the basic criteria, but timing and everything, I think, also plays a huge factor. Did you get in during your first try to get into?
I got in the first try. I got in off the
Nice.
wait list though, and I applied across Canada and in the U.S. and I got into UBC off the wait list.
Off the
so
wait
I don't
list,
think they
okay.
really wanted me. But once you're in, it doesn't matter.
So you did have a
Yeah, exactly,
lucky
yeah.
episode when it came
Yeah.
to you. So how was medical school? So medical school, like getting in is a process of its own. But what was your life like during medical school? And I think that one of the reasons we asked this question, I asked all the questions for the guests that are on the show, is for the younger generation to really understand and appreciate what it takes to become a doctor and a specialist of any kind. And it's not an easy road, but at the same time, we want to also encourage the next generation to go, right?
Yes, exactly. So it's a lot of work. Of course, nobody needs to be told that. And I was actually just talking to my wife sort of about this yesterday, and I think that it's a lot of work, and you really have to have a passion and be interested in it and want to put that work in. But you also have to find the joy and the find the pleasure in what you're doing, and not just wish that time away. So we were talking about how in medical school I took opportunities. I did volunteer things that I would not have had the opportunity to do outside of medicine. I went to Inuvik in the north and spent a month working in the working in a
wow.
hospital
That's
there for
interesting,
training
yeah.
to see something different in Canada. In residency, I went across to different places across the country and did different. I did an elective in neurosurgery in medical school, and I had no interest in doing neurosurgery. But one of the coolest days of my training was when I drilled a burr hole in somebody's head. Right.
Wow.
So like
That is
it's tons of work.
Yeah.
It's tons long hours, but you really have to find the joy and interest in what you're doing, no matter what that is.
And so, in your 4 years of medical school, and then obviously the decision to go into internal medicine to specialize in it, how did that kind of process come about? Because as you said at the beginning of your talk, that there's so many different avenues anyone can go. And how did internal medicine solidify? And then obviously my next question is like weight loss management and
Yeah.
obesity medicine.
Yeah.
So very specific, right?
Yeah. So I spent a lot of time agonizing in residency in medical school over what residency I would do, and I liked a lot of different things. But it was really internal medicine that fit with my personality and my way of thinking about the world. I like to understand things. I like to think things through. And put together sort of a puzzle, and that's a lot of what internal medicine is about, is thinking about different things and how to balance it and put it together that way. And the people that were in internal medicine, the internists that I trained with, were they were my tribe, so to speak. They were the people that I, got
You
along with, that I
resonated
resonated
well.
with. Yeah.
Okay. And then once you got into that, where did weight loss and obesity management and hypertension, where did that
Yeah,
kick
so it
in?
wasn't really what I thought I was going to be interested in
Yeah.
residency. I thought I wanted to do ICU, and then intensive care,
Unit,
and
yeah,
yeah,
the
critical
hospital, yeah.
care medicine. And I was about to apply for it for the second match, and at the last. Maybe a month before the applications, when I was getting everything organized, I was on an ICU rotation, and I was in the ICU, and I was completely miserable. And I went to the stairwell to be like, I need a minute to collect myself before I go back in and deal with this. And I was like, why am I applying to this? I don't like this. And I like so much in medicine,
Yeah.
and I don't like this. I like the idea of it, but I don't actually like it.
When
So
it comes
then-
to the action, like the
yeah,
part of it
exactly.
that
Yeah,
you're
there's parts of it that I really like, but the
Yeah.
day to day, what you're doing, the environment, it just doesn't fit my personality. So I switched away from that and did general internal medicine, and then I was thinking about different things that I could do. And one of my main mentors was in hypertension medicine, and so I spent some time working with her, and I got more and more interested in it as time went on. And then obesity medicine was just by luck. So I was talking to the program director as I was getting towards the end of my training, and I was talking to her about sort of getting a job and what that might look like. And she said, well, you're doing this hypertension training and cardiovascular disease, and why don't you work with this person I know who does obesity medicine? It's like, fine, you're the one who's going to give me a job, or I'm going to be asking for a job from. I guess I should listen to what you have to say.
I guess.
Right? And not something I'd ever thought of doing, not something I had really
Yeah.
interested in, not something I thought that there was I had a lot of hope or treatment for. It was something that really the rest of medicine has, especially at that time, got a really bit of a bad name for being futile. And then I went and spent a couple weeks with an obesity physician, Dr. Zentner, and I was just blown away by the field. I was blown away by the patient stories, what they'd experienced in medicine, how they had been mistreated, but also what we could do for them and how we could change their lives by offering them proper treatment.
That's very interesting. You bring out a very interesting point, and all the guests I've had on the show, and you talked about like the luck aspect, or sometimes things just happening. And I think a lot of them pointed out to areas in their lives, and then in the path of becoming who they are right now, where things just happen and they did something, and something just clicked for them, and now they are where they are and who they are. So it's very interesting. So luck does play a role, but at the same time, I think you also have to take steps and be true to what you feel like would work for you. Like don't be afraid to change something along the way. If you're like, oh, it's not going to be me, right?
Yeah, and you have to take those opportunities, right? I could easily have said no. My schedule's full, and I'm not gonna do this, right? But I took you take the opportunities that you're presented with, and then pivot when it works.
Exactly. Now, I want to learn a little bit more specifics about like your day to day, and like what kind of patients you see, like what do you specifically treat? Because obviously, yeah, it's obesity and weight loss and management and hypertension. But what do you do exactly? Like what do you do? What like in the day to day? Describe your day for me.
Yeah, so I do clinic medicine. So I sit in an office and I see patients who come into me, or I do virtual health as well. But it's all clinic medicine, and so not acute patients, not the sickest of the sick. And they come to me, we talk, we take a history, find out what's been going on for them, and then develop a treatment plan, right? So just like any other doctor, the nice thing compared to family medicine and what a lot of people might have experience with is we get more time. My intake visit is about an hour long to really go into what's been going on, the history, and take time to help people understand what's going on.
Okay, so probably one of the reasons you see patients for that long, because the type of patients that you see are probably coming in with a bunch of things, right?
Yeah, exactly. There's a huge mix of patients. So what's one of the things that makes obesity medicine different from other fields of medicine is that the patient population tends to be younger. So I have a lot of patients in their 20s, 30s, and 40s in my obesity practice, which you don't get as much of in other fields of medicine, of internal medicine, where there's more age-related disease, but there's a huge range of ages, and that's one of the things that I like in obesity medicine and in internal medicine in general is that you see such a wide variety of people. So especially with the pandemic and the opportunity to do virtual care, I see people from across the province. I have
Oh, wow.
patients, in
Yeah.
Haida Gwaii and Prince Rupert, all the way down to Vancouver and the Creston and all across the province. So that's really interesting. You get to see all different people from all different places. You get to see all different histories and ages and different levels of complexity in their obesity, from some people who carry extra weight and have no complications to some people who, have all the complications you can think of from obesity.
Yeah, and I would imagine that a lot of people that come in have a lot of different complications, such as metabolic syndrome or things like that are associated with obesity, which we'll get into in a little bit to really get an understanding of what it is and why it's complicated and hard to, I guess, manage. But let's jump into it. Let's get into the topic of obesity. So, what is obesity? Like, what is it exactly, and what defines it? And
Yeah. So a question that seems simple but is super controversial, right? Even the American Medical Association has said that our most used tool to diagnose obesity, BMI, is useless. Basically,
body mass index,
body
right?
mass
That
index,
people are most familiar with.
exactly. And so that is simply that your height, your weight divided by your height. The higher the number, you're divided by your height squared. The higher the number, the sort of higher your body mass index, and theoretically the more complications you should have. But of course, we can all imagine that doesn't always hold true, right? Professional athletes are going to have a higher body mass index. They carry more muscle. They have more bone mass from strengthening. And people who are very inactive, certain ethnicities, may have more complications at a lower BMI, a lower body mass index. And so when I think about obesity, I really separate it out into two things. One is adiposity, so carrying extra fat. Adipose being fat tissue, so one is simply carrying extra fat. And then adipopathy or adiposopathy, apathy meaning unwell, so sick fat. And so we can carry extra fat.
It's like a condition of sick fat, like
Exactly.
adipose tissue.
Yeah. So people can have extra fat tissue, but that may or may not be all that relevant. What matters is what that fat's actually doing. Fat is a metabolically active tissue, and it can lead to impaired glucose fasting. It can lead to impaired glucose tolerance. It can lead to inflammation. It can raise our blood pressure, or it cannot do those things. And there's various ways we define that. It depends on where the fat is and how healthy it is and all those things. And then you're just genetics, and again, your luck.
So genetics does play a factor in
absolutely.
Weight gaining and obesity and all those factors that you talk
exactly.
about.
So we'll talk about why some people carry extra weight and sort of the causes of gaining weight. But I think the first important thing is to separate out the difference between obesity and just carrying extra weight and actually having metabolic complications from that weight.
Okay. So maybe, explain that to us a little bit. Like, what is the differences between these types of adipose tissues that you talked about, and what defines, kind of like maybe good fat versus not good fat?
So at the simple level, we often think about fat that is around our organs, in our abdomen, around our organs, as more likely to produce metabolic complications. We call that visceral adiposity or visceral fat, and it tends to be more metabolically active and have more inflammation associated with it, affects our blood sugar levels more, our blood pressure, can directly, just by the mass itself, compress the kidneys, compress the heart, compress the lungs.
Just right around like the organs,
exactly.
right?
At physical level, it's both physical and hormonal and metabolic. So there's that. The fat that is at our surface level, around our thighs and on the more surface level, tends to have less metabolic activity, tends to produce less inflammation and things like that. But it's not a guarantee. A lot of that is our luck. And then what we're doing too, there's a lot of things we can do to help prevent those complications.
Okay. And so maybe explain a little bit of something that might not be clear to some people, is that visceral fat versus more superficial fat. Can you see both? Like, could one person be a little bit leaner, not necessarily show physical fat, but still have visceral fat?
Absolutely. So there's there's a colloquial term, skinny fat, right, where we don't seem to carry a lot of extra weight, but we do have extra fat tissue around our organs, and we have the metabolic complications from that fat. So that is a really important thing to note, is that just by looking at somebody, you can't tell how unhealthy they are. We like to
No.
think you can, right? We
Yeah.
like to think, okay, that person carries extra weight, they must be unhealthy. That's not how it works.
I think that's a
right?
stereotype. I think
Yeah.
that people just kind of get from that, and I think that's something people also talk about. Some of these factors associated with psychological and sociological factors associated with obesity and being overweight. Okay, so you talked about that, but also maybe can you talk a little bit about like some of these demographics of what you see? So like, what is more common? Do cultures or nationalities, your background, does that play a role? Does your sex play a role in kind of what's more prevalent, what we find, and especially like in the North American society, right?
Yeah, absolutely. So we know that there are certain ethnicities that are more prone to carrying extra weight, and then we know that there's ethnicities that are more prone to metabolic complications at a lower weight. So Black people tend to carry a little bit more weight, but they may not have the metabolic complications at the same weight. So they, would consider a slightly higher BMI to be normal compared to somebody who's East Asian or South Asian, and they're more likely to have more complications of their weight at a lower BMI.
I see.
And we know that certain ethnicities, certainly certain ethnicities are more likely to gain weight. And then in our local context, there's a lot of, and the international context, there's a lot of environment that plays into that. So we consider obesity to be often a disease of poverty. So, access to healthy foods, access to healthy lifestyle, to resources, to treatment, all of that can play a role. Stress and trauma in our life can lead to more likelihood of gaining weight. So all these things can definitely play a role.
Very interesting statement. You say that obesity is a condition of maybe like poverty, or by side effect of poverty. But I think sometimes the stereotype is, like obesity, they're just eating so much food or too much food, and maybe they're doing too well.
Yeah. So it's there's a lot there to discuss. So the first thing is we'll discuss that we often talk about obesity as a disease of overnutrition, and in fact, the word obesity comes from that idea. It comes from the Greek term for eating yourself to death, basically, and it's not really true of the physiology. We would be more right to think of obesity as a disease of malnutrition, of poor dietary quality, and so often people will have vitamin and mineral deficiencies. Even people with obesity will have vitamin and mineral deficiencies because they don't have access to healthy foods. But even if we take a step back from that, it is wrong. It's not consistent with our current evidence that it is simply a matter of eating too many calories or even the wrong kind of calories. And so this brings me to sort of an idea that I think is really important in medicine, which is homeostasis, right? The body likes to keep things stable. It wants to keep things stable as much as possible, and that leads to a lot of our illnesses. So I do hypertension medicine as well, blood pressure medicine, so I always compare obesity to blood pressure. So when we think about blood pressure, we know that the body is regulating our blood pressure. And if our blood pressure is too high, it's because the body is regulating the blood pressure up to that number. It is trying to keep it to that number, and it is very difficult for us to lower the blood pressure because the body wants to bring it back up. The same thing with obesity with our weight. The body is actively regulating our weight. It's regulating it from hormones that come from our gut, from our fat tissue, from our liver, from our pancreas. They act at our brain, and it controls not only our appetite, our hunger, our cravings, but also our metabolic rate and whether we're storing fat and where we're storing fat. So it's much more of a genetic and hormonal disease than it is a disease of eating too much.
So many factors involved. So maybe can you explain a little bit of these factors, a little bit of exact association with gaining weight, obesity, hormonal stuff you talked about, and then some of these comorbidities that you talked about.
Absolutely.
Can you kind of give us like a bit of a connection of how these things work together, because I think people are like, oh, okay, like obesity, oh, okay, maybe diabetes, but like how are all these things connected, you know?
For sure.
And
Yeah. So let's start with the base layer of genetics. Everything is built onto our genetics,
yeah,
and some people are genetically prone to carrying extra weight.
yeah,
Right? We see that in families. We see that you asked about ethnicity. So there's sort of that level of whether we have genetics that allow us to store weight. We can always think of populations that went through starvation periods, right? That were prone to starvation. They're going to have been selected for genetics that allow them to store weight, store fat, and not lose fat when they're not getting enough food, right? So those tend to be populations that are more likely to have obesity or to gain weight. And then we have our environment on top of that. So I mentioned stressors and
yeah,
traumas, medications that people are taking, other illnesses, access to food, activity levels, all of that sort of forms the next level of, can our body store, does our body have the opportunity to store weight, and how much is it going to actually do that, right? So it's that sort of balance that sets our weight. And then the complications from that, I break into metabolic complications and into physical or mechanical complications, right? So you mentioned diabetes, we mentioned high blood pressure earlier. Fatty liver disease are now most common in the Western world cause of cirrhosis and liver failure. We can have difficulties with breathing and things like that as well. Heart disease that comes from obesity. And then there are mechanical complications. And so that's things like arthritis, what you'll see a lot of,
putting
right?
pressure on the body, yeah,
Exactly, putting pressure on the body. We can have sleep apnea where there's too much pressure on our neck. We can have difficulty with breathing because there's too much weight on our lungs. So things like that, and I break it into both of those. And when I come back to what I mentioned earlier about how some people may or may not have complications from their weight, we know that as the weight goes up, we're less likely to avoid the complications. But some people will avoid all the metabolic complications, but they may still get the mechanical complications.
yeah.
Those are harder to avoid beyond a certain weight.
Of course, of course. So specifically about metabolic syndrome, diabetes, hypertension, can you give us a rundown of the connection between these and
Yeah,
weight gain? So the
absolutely.
physiology
Yeah.
behind it, how does it work?
So we group them together for two reasons. One, because they're related from a pathophysiology perspective, and because they're related from an outcomes and clinical outcomes perspective, right? So we know that carrying extra weight leads to more inflammation. It leads to signaling for insulin resistance in our body, and that promotes diabetes. That promotes our blood pressure increasing, things like that. Again, the mass of the cells itself, the inflammation that's created, can lead to those things. As well, some of the lifestyle that may produce more obesity, food choices, processed foods, high salt, high sugar, things like that, decreased activity levels can promote those same things as well. The stress and trauma and those kind of things can also promote our body to go into a stress response, increase our cortisol. That causes both weight gain and increased blood pressure and increase and diabetes.
So in one sense, obesity can cause all this, but in another sense, that extra stress that comes onto the body can also
It promotes
manifest
it's
it,
a
promotes it.
cycle, right? So
Cycle,
then
yeah.
we go on to develop diabetes, and we have impaired fasting glucose, and that promotes our body impaired glucose tolerance, and that promotes more weight gain. And then we go on medications, and some of our medications for diabetes promote weight gain, and some of our medications for hypertension promote weight gain, and then it sort of cycles in on itself. Absolutely.
Now, specifically on these other comorbidities and kind of associations of obesity and having extra weight, what is the correlation between obesity and things like cancer?
Yeah. So a more complicated question, and there's certainly cancers that are associated with obesity. So obesity again is a hormonally active tissue.
Yeah.
It increases our levels of estrogen. Which increases our risk of PCOS, which increases our risk of endometrial cancer. obesity and fatty liver is the most common cause of liver failure, which is a cause of liver cancer. So those are two sort of relatively straightforward obesity-related cancers. It becomes more complicated when we consider the social structure that brought this on, right? I mentioned obesity and access to healthcare, poverty and access to healthcare related to obesity, and we know that's related to cancer as well. At our own level as well, there's pretty good evidence that people with obesity don't get as good treatment in the healthcare system. They get less screening for cancer. We spend less time with our patients. We're less likely to do physical exam. We're more likely to ignore symptoms and just say that it's related to their weight. And
just
so they
because they're overweight, you just assume because of that, so
Exactly.
you don't get screened for other conditions and diseases.
Exactly. And because of the negative experiences people have had with healthcare in the past, they may avoid seeking care. And that's a common thing that I hear from patients is that, all their doctors want to talk about is their weight, and so they just don't like to go to see doctors. And those are patients who are willing to see me.
You got to lose weight. That's all they hear. Yeah, so it's kind of like...
Yeah. And those are patients that are even willing to see me. So you can imagine there's a lot of patients out there who would not be willing to, who are not seeing their doctors, not be willing to see a specialist to talk about this because of the messaging they've got.
Interesting. So that's something that you see a lot on a daily basis. And I think that's the part where you can make a difference and the satisfaction that comes from your part. And,
exactly. So that was one of the important things that I saw was the weight bias that our patients are experiencing.
Interesting.
Both in medicine where they're told, this is your fault. And if you just ate differently, even today, I had somebody who their orthopedic surgeon said, you need to eat. They didn't want to do the surgery because their weight was too high. They needed knee replacement, and they were told, well, you just need to eat less and move more. But you can't move more because of your arthritis, so you just need to eat less. And meanwhile, one of the things that we've been working on is not that she needs to eat less, but that she's actually working towards bariatric surgery. And as part of bariatric surgery preparation, she actually needs to increase the amount of protein she's eating. So we've actually been working on getting her to eat more of the right foods. But overall more, and now she's getting this message from a well-intentioned person who just happens to have weight bias and misunderstanding about weight, and getting this messaging, right?
Yeah, because there's so many factors you said involved that are kind of like, affecting each other in a very complex manner. It's not just about overeating or anything like that. Now, specifically, what about like behavioral and like psychological effects of obesity? So, mood disorders and conditions like that. How does that affect obesity? And then vice versa, when you get obesity, is there a direct correlation between that and causing those types of conditions and behaviors?
So again, absolutely connected, but not in the ways and not in the ways and the directness that people might think. Some people, when they have depression, they eat more. Some people, when they have depression, they stop eating, right? Some people are anxious and they eat to settle their nerves. Some people are anxious and they can't look at food, right?
Of course, it's just a behavior. Yeah.
Exactly. So it can be really variable whether people with depression gain or lose weight. And when that's treated and mental health improves, that can be variable as well. An important piece is that there's a lot of medications that contribute to weight gain in the psychiatric medication space. So a lot of our mood stabilizers, some of our antidepressants can contribute to a lot of weight gain, further complicating matters. And then there's this idea that if you carry extra weight, well, of course you're going to have depression, and all I need to do is lose weight and I'll be happier. And that is not borne out in the evidence. Across trials with effective weight loss treatments, medications, and surgery, we see that mental health does not necessarily improve. Quality of life improves, but mental health and depression scores don't necessarily improve.
Even when you get the size and the shape that you need, and you're not overweight anymore.
Exactly, because our mood is determined again by our brain, by our neurochemistry, and not by our size, right? So
and it's just one of the factors.
Exactly.
It could be like
carry extra weight and be happy, and not carry extra weight and be happy. And if you're not going to be happy, then losing 100 pounds isn't going to make you happy, right? It takes one stress away, but maybe it brings another stress on.
And do you find, and based on the scientific evidence, is there like a direct correlation between having extra weight or being obese and having or more association with mood disorders and depression and anxiety and stress?
There is definitely a link and an association, but the exact causation and directionality on that is more complicated.
More complicated, yeah. And in terms of like what you prescribe to your patients who are under this kind of complex care, does kind of seeing a counselor or psychiatrist, psychologist, does that help kind of reverse some of these effects if it is, affecting
Yeah.
it, right?
So I guess my question there is, are you asking if it helps the mood, or if you're asking if it helps their weight?
Their weight. So say, for example, like the obesity has caused that depression, but that there's a link, that is kind of like limiting them from taking
Yeah.
action, in
Yeah.
terms of.
Yeah. So to answer that question, we really have to get into the treatment of obesity.
Yeah.
Because we're gonna say some controversial things. We're gonna say some controversial things there. So I think to answer that, we'll need to get into that. But generally speaking, improving our mood does not reliably lead to weight loss. For some people it may, and for some people it won't. It'll depend on how we improve their mood medications, whether they're weight gaining or weight losing medications. It'll depend on whether the mood disorder actually contributed to weight gain, and it'll depend again on their genetics and luck.
Yeah, and very interested about in our second half of the discussion about the procedures you do, the plans and weight loss plans and all that. But before that, what is the prevalence of obesity in kids? We hear all the time that in North America, especially, the rate of kids being overweight and even obesity has risen up and it's increasing. Is that true, and is that on an increase still?
Yeah. So I don't know that I don't treat children, so I don't have the sort of most up-to-date answer for rates of obesity in children. But generally speaking, we're considering it to be more and more of a more prevalent, absolutely.
Becoming more common.
More rates of severe obesity as well. So the sort of BMIs are getting higher, and the complications, diabetes and high blood pressure and things like that, are becoming more prevalent as well, and at lower ages. That's as general. I don't know if that's true in BC and in Vancouver specifically, but generally we consider that.
Across everything. Do you think that probably has to do with kids, and again, I don't know if this is a scientific accurate statement, but it seems like kids are spending a lot more time playing video games and not being active and playing, and their fun times are not like when we didn't have video games when I was growing up. Like we just like, go in the streets and play, right? And go in the park. But I'm sure that has something to do with it.
Yeah, absolutely. So our food choices, basically, as our society westernizes, rates of obesity increase, right? So I can talk about how it's not a simple calories in, calories out balance, but we can see as our diets change and become, more Western, more processed, as our activity levels decrease, as our jobs become more sedentary, as as we become less active as children, that is associated with increasing rates of obesity. And so I do think that's likely true in children, that they're less active and more processed foods and that kind of thing is contributing.
Yeah, makes sense. One quick question, it's kind of like a side note, but it's kind of related to the diet part we want to talk about. But some people have asked me to ask you is that during pregnancy, in terms of obviously females gaining more weight and everything, and is there like a good amount of diet or eat whatever you want because you're pregnant thing? Is that a reasonable statement to make, or
no? It's not a reasonable statement to make. Now, remember that this is not medical advice, and everybody needs to talk to their own physician when they're getting,
of course,
or specialist or whatever,
course,
when they're getting advice. But generally speaking, no. The more weight we carry going into a pregnancy, the less weight we need to gain to have a healthy pregnancy, to the point that if we carry significant extra weight, we may not be recommending any weight gain in pregnancy. Generally, we don't recommend weight loss in pregnancy. And generally speaking, we want to eat, a healthy, balanced diet in pregnancy that's going to nourish the growing baby, right? So we want to have adequate protein and vegetables and less saturated fats and less processed foods and things like that. That's easy for me to say sitting here. I'll tell you, a year ago, my wife was pregnant, and when she had morning sickness, I certainly wasn't the one telling her what to eat.
Of course, of course, of course. But I think generally, even during pregnancy, more balanced, healthier diet is always good for the mom and also the baby, and also anything happening afterwards. Right?
Absolutely, absolutely.
Yeah.
Excess weight gain in pregnancy is associated with larger babies, and then that's associated with higher rates of obesity later on in life. So absolutely trying to stay healthy food choices, and then healthy activity level as well.
Absolutely. Now, in terms of going to the next topic of what you do exactly, and like the management side of it and the weight loss, can you tell us about how, so whole mechanism of weight loss, how does it work? Like where does weight loss come from? And then I want to get into a little bit of diet and just, talk about the different types and, is it just pure have less calorie going in versus what you're expending, right? So maybe tell us a little bit what weight loss is.
Absolutely. So I tried to set this up by talking about the regulation of weight and the idea of homeostasis, right? So our body is actively regulating our weight. It's controlling it's monitoring what we're eating, how many calories we're getting in, how much protein we're getting in, what our blood sugar levels are like, whether our fat cells are growing or shrinking. Sending that message, sending hormones. There's about 40 different hormones involved. Sending those messages to our brain. Our brain is interpreting that, telling us if we're hungry or full or need to eat more or need to eat less. Also sending messages back to our body about what our metabolic rate should be and whether we should be burning fat or storing fat. And we're not good at affecting that. Our body's really, really good at keeping that homeostasis and maintaining our weight and preventing weight loss. And we know this on a practical level because we can see that it is difficult to lose weight.
Yeah, everyone's always complaining like it's so hard for me to lose. You hear that sentence on a daily basis.
And even when people lose weight, it is very easy to regain weight.
Gain it back.
And I think about, the high level people. I think about Oprah. Oprah had all the support she could want. She had all the resources she could want.
Everything.
And she was not able to lose and maintain significant weight loss because her body would not let her. Not because she was doing something wrong, not because there was some magic key that she hadn't discovered yet, but because her body, her chemistry, her hormones would not let her lose weight. And so I sort of put it in that context of our body's regulating this, and there's a lot less that we can do to for most people to affect their weight than we like to think.
It's a very developing field still, huh?
Exactly.
Kind of figuring things out.
Exactly. So that's the sort of baseline that we put it in, and we see that in all, as I mentioned previously, in all fields of medicine. So I compare this to blood pressure, I compare it to cholesterol, I compare it to heart failure. When we have somebody with severe heart failure, we spend a little time talking about their nutrition, but we spend a lot of time talking about their medications, right? And we spend a lot of time talking about why simple salt restriction isn't going to manage this, right? Why a healthier diet, a vegan diet, whatever diet, diet du jour, right? Whatever's popular isn't going to manage that. It's the same thing in obesity medicine, and that's the sort of way that I want to reframe this. The other thing that I'd like to say about this is we have let the dieting industry define obesity and define treatment for obesity. We've listened to Weight Watchers.
Good PR.
They've got good PR.
Yeah.
And they make a lot of money off of it. We let Weight Watchers, we let Herbalife, we let all these companies that are making money off of us and our patients define obesity and what it is, and we need to reclaim those messages.
So
we can get into diet now that I said all of that.
I would like to get into diet because I think that's something that a lot of our audience would love to talk about. But anyways, talking about diets, like there are so many diets out there, and it's so confusing, so complicated, even for like a health professional that has a slightly better understanding than the average person. It's so complicated, and so what are these like more kind of better diets? And then I want to specifically talk about intermittent fasting. I think that's the most popular kind of diet style, I guess, that is out. And how does it work? What's the science behind it and stuff like that?
So I guess the first question is, if you're looking for a treatment, you want to understand sort of what the outcome you're looking at is, right? So does dieting work for weight loss? it's not very effective. They've done trials comparing different diets, low-fat diets, low-sugar diets, low-carb diets, high-protein diets, intermittent fasting, Mediterranean diet,
Paleo,
all these
Atkins,
things,
all these
and they
kind of.
all work out to about the same. We can, on average, about 4% body weight loss in a year. So if there's somebody who is, let's say 200 pounds, that's 8 pounds lost in a year.
Okay.
So it's not nothing. About 5%, we do see health improvement. But it's maybe not what a lot of our patients are looking for and thinking about when they plan to start a diet. And when that's what they might achieve, they are often disappointed and frustrated. And so first of all, understanding that that's realistic from a weight perspective. With that said, there may be health benefits beyond weight loss in certain diets, right? And so that's where a lot of the interest comes in. So we know Mediterranean diets associated with improvement in cardiovascular risks. There's questions that intermittent fasting might improve our glucose tolerance and our blood sugars and prevent diabetes and things like that. And the evidence is mixed on that. And so when I'm thinking about a diet, and I'm not a dietitian, and people go to dietitians, go to schools and train for this for years. When I'm talking about diet, I think about the most important factor is the patient-specific factors, right? I would say I would never tell a vegan that they have to eat meat, and I would never tell somebody who likes meat that they have to go vegan, because that person wouldn't come back and see me again, right? They just, it's just a useless waste of my breath, right? And the evidence doesn't support that one is strongly better than the other from a weight loss perspective or a health perspective. So we look at sort of what the person's health is. Is it just weight? Do they have other related conditions? Do they have diabetes? Do they have heart disease? Do they have high blood pressure? Do they have gout? Do they have kidney stones? Certain places there may be more directed diets we can recommend. So is there anything that's telling me from a medical perspective that I have to recommend one diet, or there's good evidence for one diet over the other? And if not, then we just balance out what the patient wants and what the patient's priorities are, and then try to improve the diet quality with less processed sugar, less processed foods in general, little less saturated fats. Those kind of changes are what has the best evidence for cardiovascular prevention, which is sort of the basis of where I come from, unless there's something else in that. And I set the expectations around weight loss with my patients, and I will explore with my patients what they've tried in the past, right? So by the time a patient makes it to a specialist, they've tried dieting, right?
They've done probably all 20 of them, right?
Yeah. So when I see a patient and I'm sitting on my end of the desk and I ask them, cut back on calories. Have you tried keto? Have you tried intermittent fasting? I know that they look at me and think, like, why do you think I'm here? Right? Like, it was a 2-year wait list to come see you. So why are we like, what do you think I did in the last 50 years of my life, right? They don't need to hear that from me. Earlier on, before the weight becomes as significant, I think that's when there's room to intervene and really focus on the diet quality and, healthier choices and higher, more nutritious foods and avoiding the processed foods. So I think earlier on, there is role for a diet, but understanding that it's, maybe more for weight prevention, more for cardiovascular benefit, rather than significant weight loss.
Yeah, as you said, because there's so many complicating factors. And I think, like, as you said, when you see patients, they've already tried a lot of these kind of steps, right? And then now they want to kind of more generalized and like bigger approach. Hormonal side, all the things that you said that, you're talking about. But let's bring it down a little bit so we have at least a little bit of positivity for our patient, not make it super complicated in terms of...
It's meant to be very positive. It's meant to be that you've tried dieting. It is not your fault that this didn't work. You are not doing something wrong. Your body is not letting you lose weight, and that is a normal and healthy thing for the body to be doing. It means it's working as it's supposed to work. And enjoy your food, make healthy choices as much as you can, enjoy that, and don't put stress on every single bite of food that you have. Just enjoy your life.
Enjoy your life. So now let's bring maybe to a specific case or scenario that you might see, because that's such a common thing. So say someone doesn't have too many comorbidities. They happen to end up at your office. They have a little bit of weight issues. They're not obese necessarily with all these comorbidities and complications. And they want to get an advice from you from a dietary perspective. Say, hey, can I try intermittent fasting or this? What is, from that preventative measure of, not gaining the weight that they might if they don't do some dietary modifications? Like, how good is intermittent fasting because it's probably the most popular practice. How
Yeah.
does it work?
Yeah, so we don't have amazing evidence to tell us how good it is for weight prevention.
Yeah.
And the most important thing when I think about, prevention of weight gain is this manageable for the person? Does it work for them? Do they like eating that way? And again, it comes back to the individual factors, right? Some people don't eat breakfast and they're miserable the whole day, and some people aren't hungry at the beginning of the day and have been told their lives they need to eat breakfast and they hate it, right? So it's again matching the right person to the diet, and then. From there, intermittent fasting, there is some evidence that it's, at least as effective as anything else, as any other diet. When we eat for fewer hours in the day, we're probably generally eating a bit less. Most of the studies do consider it to be a reduced calorie intermittent fasting diet. It is thought that they're going to eat a little bit less. It avoids some of the snacking time that it would be maybe more common in the evening, and gives you sort of that reason to limit that. And then it gives you that time where your body's not getting food. And the idea is that you don't stress, you don't produce as much insulin, you don't sort of stress your system as much during that time.
When you're not eating. So
exactly,
that 12, 16-hour cycle, whatever cycle it is.
Yeah, it allows your body to use the sugar that you've eaten in the day, in the part of the time you've eaten. Now, practically, it used to be that we recommended 3 meals, 2 snacks, regular eating all throughout the day, right? So now we've swung to intermittent fasting, and when we have big swings like that, it often tells you in medicine that either there's a really good study and it tells us really clearly what we need to know, or we just don't know what we're talking about. We don't have good evidence, and we're just trying different things to see what fits. And a lot of things in the diet space are that somebody else, the diet industry, telling us, trying to sell us another book, trying to sell us what we should be doing,
and stuff,
and the science is lagging behind it because people are just desperate for something that's going to work. So I think intermittent fasting is fine. If that's how you like to eat 2 meals in a day, it works well for you. Your energy is good. It doesn't lead to more snacking and cravings and unhealthy food choices. I think it's a great strategy. If you're somebody who needs to eat regularly through the day, or you get big blood sugar swings and you feel really miserable and you're hungry all the time and you're hangry and grumpy, it's just, it's not for you. And that's fine. The evidence doesn't say that it's so good that we need to recommend it for everybody.
So just specifically about intermittent fasting, because a lot of people ask me to ask you, is how does it work on the body? So I know there's a carbohydrate metabolic cycle, right? And then there's a fat metabolism, there's a protein metabolism. And why does intermittent fasting, when you have that large gap of not eating, how does that start burning fat, as they claim? Like, how does that physiology work? Can you explain that a little bit to us?
So there is. So I wouldn't say that I'm an expert on this question, and I wouldn't say that it's necessarily totally understood. We know that the body preferentially uses carbohydrates as our fuel system, right?
Source of energy.
So if we have carbohydrates available, our body will use them because they're the most simple for our body to use. If there are no carbohydrates available, our body will start to use fat and muscle as well.
Protein,
and
protein muscle.
So part of the idea of intermittent fasting is that we use up the easily available glucose stores, the glucose in our blood. We're not providing a constant stream of glucose, so the body starts to depend on fat stores. It's the same idea behind ketogenic diet. We're not providing enough blood sugars, enough glucose, so our body starts to develop a mechanism to start to prioritize fat digestion. It's a really nice theory. We also used to think about it with this idea of the aerobic, the exercise burn, and we should stay in. If we want to burn fat, we should keep our heart rate in a certain level because our body can preferentially use fat at that level, and it just doesn't bear out in the evidence that it makes a difference in long-term weight management.
The evidence, scientific evidence behind it, even though the theory on paper and like the physiology behind it might sound like it works, but it just doesn't work like that in the body.
Our bodies are so much more complicated. As I mentioned, 40 different hormones. We're only just understanding how the body's regulating our weight. And so we can have these nice theories and test them out, and it's a really great way to help us understand more about it, but it's not really what happens in practice.
And I kind of answered that question. I think the next question was, exercise? Like, is there a difference between weight training, aerobic training? Is there an evidence for like?
So you're going to come back and you're going to hear me say the same thing I've said before, which is that this isn't effective for weight loss,
Yeah.
right? And the evidence really clearly states that. And I think that you as an exercise, you live in the exercise space, right? Like,
Yeah.
I'm
always telling people
that exercise. Yeah, you recommend exercise, but you see that for most people, it doesn't lead to weight loss, right?
Not significant
amounts of weight loss. Part of that is because we're putting on muscle, and muscle weighs more than fat. Part of it's because it increases our hunger. Part of it's because we get a health halo effect, and we think we did exercise, so maybe we can eat something, less healthy or that kind of thing. But in reality, it's because of that, because our bodies are just really good at maintaining our weight and not letting us lose weight. And if we think about it, if we're exercising more, it probably meant we had to try harder to hunt for food. It probably meant there was less food available, or we were in a time of stress and we were running away from danger. And so our body better not just let us lose all our fat stores. That's when we need it the most, right? So we better become even more efficient at holding on to our fat, because it means there's not going to be food available. So if we go back to that level, it sort of makes sense. Exercise is important for our health. Don't worry, I'm not going to sit here and tell you that exercise doesn't matter.
Of course, no, it's very important.
Exercise is very important for our health.
Muscle gain and cardiovascular system.
There is good evidence that exercise, especially as we get to sort of over 150 minutes, up to 250 minutes, is good for weight maintenance. As we get to sort of really extreme levels of exercise, over 250 minutes a week and higher, so about an hour or more a day, we can start seeing a little bit of weight loss with that. But it's not a guarantee. But it is important for prevention of diabetes, lowering blood pressure, healthy aging, prevention of fractures, all of that. And what I recommend to all my patients is a mix of aerobic and resistance exercise, and to not focus on the scale number. If they're doing resistance exercise, they're putting on muscle, but the scale's not moving or it's going up a little bit. Ignore it. Don't focus on the scale. Focus on how you're feeling, shape, size, how you're feeling, your energy levels. Do you feel stronger? Do you feel healthier? What are you enjoying? Are you enjoying this exercise? Trying to find something that you enjoy.
Perfect. Next set of questions is the medical procedures and like medicinal side of things. So Ozempic, I think, is the top name that comes up with weight loss nowadays.
Exactly.
Right?
Yeah. So when you can't talk about weight loss without talking about Ozempic. And so I want to sort of bring this back again to the hormonal balance, right? So if we think that there's a bunch of hormones involved in our weight, that's what Ozempic is. It's a recreation of one of our natural hormones that's involved in weight regulation. It's called GLP-1, and it's normally released when we eat. When we eat protein, it's released from the small intestine, sends a signal up to our brain, and tells us that we're full, right? So we eat, we feel full. The process takes about 20 minutes if we're eating, and that's why we say it takes about 20 minutes to start feeling full after we eat, because it takes that long for those hormones to act in our brain.
Yeah.
There's a bunch of other ones come from our gut or from our stomach or small intestine, etc. But that's one of them. So Ozempic gives us back that hormone. Other medications, Wegovy is the same thing as Ozempic, but different dose and labeled for weight loss instead of diabetes. Saxenda is very similar. Victoza is similar. Mounjaro or Zepbound, tirzepatide, is actually is one medication that acts at two hormone receptors, so both GLP-1 and GIP, to further produce that fullness response. Now, the important differentiation, and a place where I've gotten into fights with colleagues, is that I spoke about how it's not calories in, calories out, and our body does what it wants to do, and it's not as simple as eating less. And then we talk about medications that produce a fullness response. And so people will say, it produces a fullness response, so we eat less, so that's how we lose weight. But I spent all this time telling you that it's not how we eat.
That was kind of like
and so people just sort of accept this and are like, but we eat less, and it becomes a problem, because then we have people who are saying that, Ozempic can help you make changes to your diet, and then you make the changes and then you can come off the medication, and if you make enough changes, maybe you don't need it long term, and all of these things, and it goes against what I've spent the last, however long trying to build up, is that it's not simply eating calories in, calories out. So what Ozempic actually does is it acts at that hormonal, at that starvation center, and pulls us out of that starvation response. And there is some evidence that it doesn't increase our metabolic rate, but it probably reduces the metabolic adaptation to weight loss and eating less. So normally we eat less, we're losing weight, our metabolism slows. It probably prevents that. But there is a lot that we don't understand in how it works beyond simply having us eat less. And so that's an area that is being studied, but that you'll hear this sort of that I want to really highlight the sort of difference in how we talk about it and what's out there as an appetite suppressant. And we have other appetite suppressants that don't really lead to weight loss in the same way. So there is something different about it.
This one's pretty effective drug. I think there's a lot of everyone's like talking about it, and I know a lot of people use it for aesthetic purposes, just to lose a few extra pounds and look lean. What are your thoughts on that?
Yeah. So I will be honest and tell you that I don't care. So people can get Botox. People can get Botox, and you know what? They can get Botox. They don't need to have migraines. They don't need to have muscle spasms. You can get Botox because you don't want to have wrinkles. Fine, right? It's not what I do. I don't do Botox. I don't want to do Botox. I don't want my practice to be cosmetic medicine because I don't find it interesting. But if that's what you want, I don't know. It's safe. It's probably safer than a lot of the other supplements and crash diets and things people are doing for weight loss. I'm not. I just am not. Don't really want to be involved in it because I don't find the conversation around it with patients to be particularly interesting or satisfying. But if that's what patients want, I don't really care that much, and I think that patients should be allowed to make that choice. Now, when patients do talk to me about that, when I see patients for hypertension and they're asking me about that, the things that I'll highlight is that it acts as a long-term treatment. So we go on it and we'll lose weight. If we come off of it, we expect to regain weight.
Regain some weight.
And it's quite expensive, and it's not covered for, generally speaking, not covered for cosmetic reasons. So, and the risks, the risk to benefit ratio changes, right? So there's, all the risks are still there. It's pretty safe medication, but the risk of, nausea and vomiting and, stomach issues are all still there.
Could be there.
Any risks that we don't, it's been around a long time. We have pretty good safety data. A lot of the safety concerns are not actually shown in the long-term evidence. But maybe we'll come up with some other safety issues that we don't know about. They're all still there, even if you're using it for cosmetic reasons. But the health benefits are smaller, so you have to weigh that on your own priority
risk
levels,
versus benefit
right?
ratio. I read that there's some evidence coming through that there might, in some cases, have Ozempic might have caused some negative effects of actually some people have gained weight from it. Is that true? Or
So I have not heard any evidence of people gaining weight while on Ozempic.
Yeah.
People are on it and then
Coming off of it,
you can regain some, all, or more weight than you
More
lost,
weight,
just
okay.
like any other diet. If you go off of it, any other treatment, we say a blood pressure pill, you're on it, your blood pressure's down, you're off of it, it goes back up. We're not surprised by that when we talk about a blood pressure pill. For some reason, we think that an obesity treatment is going to be different. It isn't. We should just think about it the same way.
Fair enough. So, okay. Yeah. Pretty effective drug then. Now, other procedures, surgical procedures, can you tell us a little bit about that and what's available and are there risks associated with them and when do you maybe consider those for your patients?
Yeah, absolutely. So we try to match the right patient for the right treatment, and a lot of that has to do with how significant the obesity is, not necessarily just the BMI, not necessarily just the amount of weight, but those metabolic complications and the impact of those. So both the more weight somebody carries, but also the more complications they have from that weight, diabetes, high blood pressure, heart failure, fatty liver, all of those really give us evidence that there's going to be more benefit to the surgery. For example, there's pretty reliable for somebody with diabetes, about 80% chance of curing diabetes with bariatric surgery, so they can be off of all of their diabetes medications with normal blood sugars. So that's one of the really powerful effects. And again, highlighting this balance is that the improvement in blood sugar happens before the weight loss. So you come out of surgery and already your blood sugar is improving, even
We're
before the
just
blood
taking
sugar.
the weight down, like
Even with before the weight loss,
decreasing
because you've changed the gut and you've changed the hormones in the body. So that's how surgery works, is that it increases the natural level of our fullness hormones, things like GLP-1 and GIP, decreases some of our hunger hormones depending on the type of surgery. And that process is also involved in regulating our blood sugars, and that lowers our blood.
Interesting.
That simply lowers our blood sugar without having to, before the weight loss is maximized.
Wow. So when you say surgeries, can you tell us what surgeries? Because I think the number one thing that comes to people's mind is liposuction.
Yeah, so that's not the surgeries we do for obesity, right?
Yeah.
So when we think about obesity surgery, we're called bariatric surgeries. We're
Bariatrics.
thinking about them as more metabolic surgeries. So we want surgeries that actually affect that metabolic and hormonal regulation, and there are surgeries that are on the gut, on the GI system. There's two main surgeries that we would be thinking about. There's gastric sleeve, where they take out 80% of the stomach, or there's gastric bypass, where they
That's the one I
bypass
think's
the
famed,
stomach.
well
Exactly,
known,
that's
yeah.
the one that's been around the
Yeah.
longest. So they bypass the stomach in the first part of the small intestine, so food goes straight from the esophagus into the second part of the small intestine. It's been around the longest. It's stood the test of time. Lots of things have come and gone. Gastric banding, putting the band around the stomach, various different surgeries. The sleeve we're really excited about, and now we're a little bit less excited about it as we get the long-term evidence from it. But the bypass is really what's stuck around. And we often talk about it as a restrictive surgery. We'd have this just a small pouch of a stomach. We can eat less. It's not really what it's about.
The hormonal
it's about
changes,
the hormonal
yeah.
change, the increasing the fullness hormones, this resetting the set point of our weight in our brain so that it's not trying to pull that homeostasis back up to where we were before, but up to a new lower level. And so we can see about 35% body weight loss on average with that.
That's
So it's
significant,
quite
yeah.
significant, and more importantly, improvement in our metabolics, improvement in diabetes, blood pressure, sleep apnea, fatty liver, things like that. Pretty high rates of diabetes, 80% cure
Decrease,
rate.
yeah.
Hypertension and sleep apnea a little bit lower, but still quite significant.
That's it. Like, any side effects, like any negative effects of some of these that
Of course.
Yeah.
So I was actually talking to a patient today who said that they don't want surgery because it's a quick fix. And they don't think they did this to themselves, so they don't want a quick fix.
Yeah.
And I said, first of all, you didn't do this to yourself, and here's all the hormonal reasons. And also, bariatric surgery is not a quick fix. So with any surgery, there's risks of infection and
course.
bleeding and anesthetic risks and things like that. But when we think specific to bariatric surgery, we think sort of two main sort of categories. There's nutritional issues. So if we're not getting in enough protein, if we're not getting in enough vitamins, we can become low in those because our body's not able to absorb and get as much out of what we're eating. So we monitor closely, and we use, this is one case where we do prescribe diets that are high in protein. We get extra supplements and things like that. So that would be sort of one area. Then the other is more mechanical issues. They've changed the gut. So there's, you can get obstructions and surgical issues that way. There's, I guess, other issues. There's any time we're having such significant rapid weight loss, we have risk of gallstones, a little bit of risk of pancreatitis, things like that. And then in the long term, there's chance of weight regain. And so this is a case where, sometimes it happens, just happens. Sometimes it's because we're having, more sugary drinks and things like that that can promote weight gain. So we do a lot of work before and after surgery to get people ready for surgery. The biggest challenge with surgery in BC is the wait times. It's about, if you get referred directly to the surgical program because your family doctor thinks you should have surgery, it's 2 to 3 years before you talk to anybody. Before you talk to even somebody to say, is this something that I could possibly do? And then you talk to them, and then they say, is it possible? And so sometimes people wait that 2.5 years. They talk to them and say, well, no, you have have this condition, so we can't do surgery for you, and then you're back to where you started, right?
So it's not an option for everyone.
Exactly,
Like you have to,
or it is an option, and then you start the process of getting ready and the dietary change, and it's another 6 months or a year of working with the team to get ready for surgery. So I would say, if you get referred to the surgeon, expect 2.5 to 4 years before you actually have your surgery.
Surgery done. So
They limit the number of surgeries in BC. They do I think they increased it now to 400 surgeries a year in BC. And if we consider the rates of obesity in BC to be about 25%, now that's BMI greater than 30, not all those people should have surgery. But even if we said 10% would meet the criteria for surgery, that's 500,000 people in BC who could have surgery today, right?
Or could be potential candidates for
it.
it.
Could be potential candidates, and we can do
it.
300 a year. So
Yeah.
it's
one of the issues with our healthcare system that we need
Exactly.
to work on. So having said all this stuff and all these different kind of approaches and kind of this comprehensive approach that you're talking about, it seems that it is significantly more complicated than people might think. But what are the positives? Like where's the green light that we can give hope to people? Say, okay, you know what, it's getting better. We're able to manage this a lot better. What can you tell us?
So I think that there's a bunch of things. The recognition of weight bias, obesity bias, and separating out carrying extra weight from our health, I think is really important to our patients. And we're having more and more understanding of that as we, as it is out there that maybe BMI isn't the only tool we should be using, right? You can carry extra weight and it doesn't mean you're all that unhealthy, and it doesn't mean you need to lose weight, and you can focus on diet and nutrition and be healthy even if you are even at a bigger size. And so there's more acceptance of that, and we're better understanding the tools we can use to differentiate, okay, who actually is at risk from carrying extra weight and who is pretty healthy and we don't need to do more. So that's the first level. The next level is better understanding that patients experience, that we should accept and listen to our patients, their experience when they're telling us they've tried dieting and they haven't lost weight. We shouldn't tell them that they're doing it wrong, that they're lying to us. And so that should be a message that our patients are getting, and that should feel a little bit hopeful that they're going to, be listened to. And then that there are highly effective treatments available for people that want them, that meet criteria. There's medications, there's more medications coming out. And then surgery is available, is effective, and can drastically change people's lives.
So the future is very hopeful.
Absolutely.
It's getting better and better every day. Medicine is advancing, and we're able to tackle this complex problem a lot better and better.
Absolutely. I wouldn't have gone into this field if I didn't feel hopeful about the future of it.
That's fantastic. I think that's a good way to end the segment. And thank you so much for coming, Jesse. I really appreciate you having
Thank you for having me here.
Thank you so much.
Thanks.